we're going to see pericardial effusion and some pericardial tumors. The pericardial effusion is the accumulation of some fluid between the pericardial serous layers. This is, here we have the heart, we have the epicardium, which is here and is like fused with the myocardium. Then we have the parietal pericardium that is also part of the serous pericardium, and at the end we have the parietal, the fibrous pericardium that is touching, is fused with the parietal pericardium. So in between these two serous layers, the visceral or epicardium and the parietal pericardium, we have accumulation of fluid. This could be acute or chronic. In acute, usually is after cardiac surgery or pericarditis or some collagen vascular disease. If it is chronic, usually is secondary to some direct expansion of some tumor that is causing this pericardial effusion, would be breast or lung, and also bone tumors, and some conditions would be HIV or lupus. Usually this is chronic, and because it is chronic, this means that the ratio at which we are accumulating fluid here in the pericardial space is slow, and because it is slow, the pericardial effusion is going to be much larger than a pericardial effusion in a acute pericardial effusion. The treatment is pericardiocentesis for both. Here we usually will relieve the symptoms if we give fluids, but here give fluid maybe will not resolve any symptoms. The patient present could be with some distant heart sounds, could be shortness of breath, a little maybe cough. In chest X-ray, we will see the cardiac silhouette would be enlarged because of the pericardial effusion, enlarged cardiac silhouette, and maybe we also have some compression symptoms. This would be like deepening of the voice or the cough or something like that. This was pericardial effusion. Now, the pericardiocentesis, we will do it in the 5 or 6 intercostal space and sternal border, left sternal border, or just inferior to the kyphoid process. Alright, and now for pericardial tumors, these are very rare, but we have them. We have sarcomas, we have mesothelioma, fibros, so solitary fibros, and germ line cells. This we usually see in pediatric patients. This is usually benign but tends to recur. The sarcomas, the most common type is the synovial type, and the mesothelioma is associated with asbestos exposure, but with asbestos exposure we more likely are going to have lung cancer, and the lung cancer that we would get would be bronchogenic and not pleural. But if we have some surface cancer, would be pleural. Much rare the pericardial tumor.